I became very interested in the role of inflammation in lung disease, and you may ask why, but the reason really is that pretty much every lung disease is fundamentally a disease where there is disordered inflammation. With the possible exception, I would have said a decade ago, of lung cancer, but actually there is abundant evidence now that immune regulation, dysregulation, is really important in whether cancers grow and metastasize. So, you know, inflammatory responses become ever more important, and of course extremely topical at the moment, because sadly the major reason for death in COVID-19 infection, well, there are two main causes. One is disordered lung inflammation leading to respiratory failure, and the other is thromboembolic disease, clot formation, which itself may well be triggered by the disordered inflammatory response. So you will know probably in great detail that you can think about your immune system in two parts. And I've always been more interested in what you might call the cellular innate immune response, which is the immediate early response to particles that we recognize as being damaging. And we can recognize that without ever having been exposed to whatever bacterium or virus or noxious stimulus it may be. And in terms of numbers at least, the most important cell in our innate immune response is the neutrophil. And it is the first cell to leave the bloodstream and migrate to sites of injury or infection. And it's able to engulf and kill bacteria and sometimes viruses. So it really has a hugely important protective role. But behind that is a really fundamental paradox, which is that these cells are essential for our protection from infection. Without them, we would die within weeks of uncontrolled infection. And yet, these cells contain an array of enzymes and oxygen radicals and so on that are able to cause massive tissue destruction. So the other end of the spectrum is a disease that I see a lot of, chronic obstructive pulmonary disease, and you will probably know that this is destruction of the lung parenchyma, the airways and the alveolar spaces, and the neutrophil and the enzymes that it produces are a major cause of that lung destruction in COPD in the context of inhaling tobacco smoke or other inhaled particles. So we have this obvious paradox in terms of lung disease. We desperately need to have competent neutrophil responses in diseases such as pneumonia, and you can see a nice example of a lobar patient with a lobar pneumonia here. And even in the pre-antibiotic era, patients often survived lobar pneumonia because of an effective neutrophilic response. But then on the other side of this balance, we have other numerically really important diseases like COPD and acute respiratory failure, such as you see on ICU, that are neutrophil-driven diseases. So the therapeutic challenge is how do you control this process? You can't have no neutrophils, you can't have excessive neutrophils, and you have to think about therapies that might modify but not abolish this inflammatory response. And it's further complicated, again, because we think about diseases of infection, of which pneumonia will be a great example, and we think about diseases of inflammation, ARDS, but in the middle we have diseases of which COPD is a great example, where you have both. So my lab group, and I'm not going to talk a lot about it, but we're very interested in how you can have both excessive inflammation and failure to clear bacteria in the context of chronic obstructive pulmonary disease.